فيسيولوجي لمعهد القلب كله. أنا سعيدة بوجودي ما بينكم. أنا الحقيقة العنوان الأول كذا مرة جاي مختلف، بس أنا بتكلم عن ECG patterns in pediatrics. The intended learning outcome of my talk will be to recognize the normal and abnormal ECG patterns in the pediatric age group, and by no means I can speak complete. يعني طبعا ده شابتر في كتاب أو كتاب بحاله، فإحنا هنحاول ناخد بس الحاجات البسيطة اللي تقول إيه الفرق بين الأطفال والكبار. In the ECG there are age-related variations. The ECG evolves with age. The heart rate decreases with age. At birth, the heart rate in the neonate ممكن يبقى 150, maybe up to 230 if he's crying, vigorously crying. Till he reaches an adult, the 80 beats per minute, well, 60 to 90. So what happens during this time? The intervals increase with age. They are smaller, shorter in the infancy, and they increase with age. At birth, a baby with right ventricular dominance. In the newborn, it changes to left ventricular dominance in the older infant, child, and adult. The change of the left ventricular to right ventricular ratio from after birth to adulthood helps us understand the cause of these changes. يعني الريشيوز دي مهمة قوي. At birth بنلاقي إن the left ventricle is 0.8 وإن the right ventricle 1 أكبر منه. إنما at 1 month the ratio is 1.5 to 1. At 6 months it's 2 to 1, and the adult is 2.5 to 1. And this change in the ratio of the left ventricle to the right ventricle is responsible for the ECG changes. So if you want to comment on an ECG, you have to know the age of the patient, particularly if you're in the pediatric department. The normal ECG of a 1-week-old infant is abnormal for a 1-year-old child. And the ECG of a 5-year-old child is abnormal for an adult. If you look at the newborn, there is right axis deviation. ده الطبيعي بتاعه. Right axis up to 180 degrees. والprecordial leads show right ventricular dominance. والR wave تبقى موجودة in V1 and pure S in V6. You can see if the tall R in V1 لو زادت عن 10 millimeters suggest right ventricular hypertrophy، لأن هعرف إزاي right ventricular hypertrophy in the neonate. The RS ratio is more than 1 in right chest leads, relatively small in the left. بلاقي عندي small QRS voltage, T waves are of low voltage كله صغير, and the T wave in V1 is inverted after 48 hours. يعني أول 48 ساعة في العمر تبقى upright. بعد كده it is inverted. So an upright T wave more than 48 hours of age suggests right ventricular hypertrophy. ال T wave عندنا مهمة قوي as we are following these children. وأدي نيونيتا هو أقل من 24 ساعة بنشوف فيه right axis وشايفين فيه dominant R wave in V1 in the right precordial leads V3R and V1, and we are looking at the T waves. It is upright. لو فضلت بعد أول يومين معناها right ventricular hypertrophy. نيجي ما بين 1 to 6 months ألاقي right axis deviation أقل، ابتدى يقل بقى 120 degrees. Still dominant R in V1. The RS ratio in V2 is close to 1. خلاص ابتدينا الليفت ventricle ابتدى يكبر. The RSR dash in V1 is not abnormal للأطفال. It can be present. Large voltages in precordial leads suggestive of biventricular hypertrophy might be present. يعني أبص على ECG وهيلاقي إن there is biventricular hypertrophy. You have to refer to reference anomalies and ما بيبقاش right ventricular hypertrophy. The T wave is negative across the right chest leads. T wave ألاقي في right chest leads كلها it is negative and it is present here. Thus, in assessing the pediatric ECG, we have to refer to normal values for age and increase R and S wave voltages. And these are the reference values present في كتب كتير. بس broadly كده لو ال R وال S وال precordial leads كانوا حاطين في بعض بنعرف إن في ventricular hypertrophy. At 6 months of age to 3 years, ال QRS axis بقى يبقى normal 90 degrees. RS ratio in V1 is close to 1. the R wave is clearly dominant in V6. خلاص الرايت ventricle ابتدى يكبر. It's going to take an upper hand. Many children of this age برضه اللي عندنا large waves is suggestive of biventricular hypertrophy بس ما بتبقاش true. So when we look at this ECG of 1 year old, طفل بيبي عنده سنة، ولكن إن T wave upright موجودة في V1, this is suggestive that there is right ventricular hypertrophy. Between 3 to 8 years, الadult QRS progression in precordial lead هتبان بقى. الadult normal progression, dominant S in V1 and R in V6 اللي هو زي العادي. Large precordial bulges persist, maybe Q waves في left precordial leads, and T waves remain negative in the right precordial leads. Between 8 to 16, a QRS range from 0 to 90, adult QRS progression ماشية. V6 الR in V6 larger than adults. High J point might be present هنقولها تاني بنتكلم عنها. T wave variable may be upright in V1 but remains negative in V1 to V4 and this is to late class. الT wave مهمة قوي عشان كده هنقول الnormal variance in children. The T wave in infants more than 48 hours it should be inverted. In the right precordial leads, T wave inversion it persists throughout childhood with inversion to V4 being accepted as normal. There is a progressive change to an upright T wave across the precordial leads from left to right as the child grows. يعني left ventricle taking over. Until 8 years of age, لو طفل عنده لحد سنة 8 سنين upright T wave in V1, this is considered a sign of right ventricular hypertrophy. Many children will show persistence of an inverted T wave in V1 until their late teens. وحضراتكم اللي فيكم أو كلكم adult cardiologists تعرفوا طبعا إن في حتى young adults بيبقى عندهم juvenile inversion of the T wave. The RSR- complex, 7% of normal children under 5 of age have an RSR- complex and few of the older children. وبالتالي لازم يبقى لي criteria أعرف إمتى هي abnormal. When is the RSR- considered normal? When the width of the QRS shouldn't be more than 10 milliseconds longer than the normal, and the R- voltage in V1 should be less than 15 in infants and less than 1 year and less than 10 in more than 1 year. So in right ventricular hypertrophy, I find the R- taller than the R with increase in voltage. And this is an example of right ventricular hypertrophy. الR- أعلى وهي upper limit of normal شكلها معدية التام فهي suggesting of right ventricular hypertrophy. في الادolescents كمان بيبقى عندهم early repolarization is commonly seen with an elevated J point most obvious in the mid precordial leads ودي حاجة طبيعية في الأطفال. This is a completely normal finding and must be distinguished from pathological elevation of the ST segments. There are pediatric dysrhythmias that do not require treatment. وحضراتكم aware طبعا بالساينس arrhythmia موجودة في الأطفال. There's the wandering atrial pacemaker والisolated premature atrial contractions موجودين كتير في neonates. Isolated premature matrix contractions and the first degree heart block. This is a sinus arrhythmia وبنلاقي طبعا RR irregularity بس it is sinus LP وراه QRST بس بنلاقي pauses هي موجودة أو prolongation هنا اهوت فنبقى عارفين إن دي sinus arrhythmia and it is present in children and some more in some يعني في أولاد عندهم very marked لدرجة إن الواحد الدكتور بتاع الأطفال وهو بيسمع بالأوسكلتيشن بيسمعها زي ما تكون drum beats and they get alarmed and they send the child for an ECG. The wandering atrial pacemaker might be present in neonates وهي ممكن تخض لكن هي atrial shifts pacemaker shifts from the sinus node to another side. It's a normal variant but gives an irregular rhythm. وممكن انها تروح بعد كده. اي حاجه ما دام معايا normally structured functional heart I'm not alarmed from it. The premature atrial contractions are common in the newborn. It is benign in the absence of underlying disease. There is an early P wave sometimes with different morphology than a sinus P wave, and it can be either not conducted to the ventricle, followed by pause, or conducted with an aberrant or wider QRS complex. زي ما احنا نهو شايفين it is not conducted here, followed by the pause, and it is very common. Premature ventricular contractions, they are uncommonly seen in children, but they do occur. And we consider them benign when they are unifocal, are the most commonly encountered. premature ventricular contractions زي الكرايتيريا بتاعت الادلتس اللي هو لما تبقى unifocal they disappear with exercise associated with structure and function in normal heart, we consider them benign. No therapy is needed. But again, if you meet a patient, احنا بالنسبة لنا it is not that common. If you find it and it is causing some trouble, we just want to make sure do an ECG, do an echo. Please be aware that it is in childhood that we start to put children for exercise. بيلعبوا رياضة. We need to know screen. أنا سمعت دلوقتي PVC، شفتوا شوية PVCs. أنا ما أعرفش وقت الإكسرسايز هو بيحصل فيه إيه. إحنا we have to be a little bit more aware of sudden cardiac death. وجايز أنا عشان we are acquainted of this problem. I don't take things easy. لما بلاقي حاجة it is benign. Yes, it is benign, very good. But let us make sure that with exercise it disappears. You can even ask the patient to do a mild exercise in your office. يعني يعمل شوية مجهود كده واسمعه. أشوف دي بتروح ولا لأ ولا تزيد معاها. Multifocal or pair PVCs are more worrisome and advised to avoid caffeine with other stimulants and mean drugs. لو احنا عندنا problem كبيرة جدا في مصر ان احنا كل الدكاترة احنا عندنا دول الأطفال أنا عارف I'm a pediatrician to start with. So I know what pediatricians write as treatment with the rising rate of asthma in Egypt. احنا أزمة كانت قبل ما وانا بشتغل وانا صغيرة كان يبقى عندنا 2 في وسط ال10 عندهم أزمة. دلوقتي عندنا 7 و8 في وسط ال10 وكل chest infection the new infections احنا بقينا نسمع حاجات ما شفناش قبل كده بتيجي ببرونكوسبازم معناش بسازماتيك اصلا يعني احنا كادلتس بص تلاقي الراجل الكبير يجي له bronchospasm. Doctors prescribe a lot of Ventolin بقى والبيتاسيمز and so on and this will nasal decongestants the multi-drug use and abuse the patients take the same فورمولا يعني نفس النوع باسم مختلف 3 مرات والله ده انا استخدمت النهارده نو فلو وتريامينيك وما اعرفش وكميه حاجات على بعض انتي and thus they precipitate attacks and they enter into PVCs or even the مشهور عنهم they precipitate supraventricular tachycardia. First degree AV block is considered normal لو مفيش اي حاجه معاها in 6% normal neonates. These are the intervals and it generally doesn't cause bradycardia since AV conduction remains intact. But we again, in the pediatric age group, we have to exclude. We're not in rheumatic activity, this is not rubella or mumps, there is no hypothermia, cardiomyopathy, electrolyte disturbances. These were the normal patterns and very rapidly we've spoken about them. Now I'm going to talk about abnormal patterns, particularly in infants and children that I know maybe others you will not be seeing these diseases in adults. Case 1 is a 10-day-old newborn with bradycardia. Baby لسه مولود عنده bradycardia. Is it sinus or a complete heart block? We want to know. If it is sinus, it must be something secondary to something. We don't know it is second. There's nothing apparent. We have to think of a complete heart block which develops in utero between 18 to 20 weeks of pregnancy. It's common in infants with systemic lupus erythematosus mothers and sometimes the mother is not diagnosed. يعني في أمهات بيتشخصوا إن هم عندهم lupus بعد ما يخلفوا طفل complete heart block. بيبقى عندهم anti-Ro and anti-Ra antibodies. Complete heart block is a permanent defect in these babies and there's a wide range of conduction defects while the baby اتولد infant of the lupus mother and we're very happy he did not have a block and then he starts having it prolonged PR interval. احنا قلنا عليها normal but I have to follow up and no, there is nothing abnormal in that baby going to a 2nd degree heart block and then to a complete heart block. And this is an example of an ECG of one of the patients, of our patients, with a P wave marching about the atrial rate 150 beats per minute and the ventricular rate less than that و60 بالنسبة لنا في النيونيتي حاجة واطية. Abnormal patterns particular to infants can occur due to inborn errors of metabolism اللي هي بتبقى موجودة في الأطفال في السن ده which is an important cause of arrhythmias early in life. Infants in the neonatal period presenting with difficulty in breathing are frequently misinterpreted as a pure chest condition. Auscultation of the heart with the gallop rhythm, the muffling and so on is not that easy for everyone. And cardiomegaly in this patient might be suggested that there's a cardiac abnormality we have to look for a cardiac caused by ECG and echo. So we have to look at the patient with hypotonia and respiratory distress soon after birth. He's tachypnic, tachycardic with a level, with a gallop rhythm and tender liver. The ECG showing Wolff-Parkinson-like pattern with a short PR, called QRS, and ST segment abnormalities as you see in the ECG. This patient by echo was proved to be having a diffuse hypertrophic cardiomyopathy. This clinical picture is suggestive of the Pompe disease, glycogen storage type 2, in which there is a lysosomal alpha-glucosidase deficiency. Another neonate 10 days old, during examination was tachycardic with subtle convulsions. يعني subtle convulsions يعني he's not pure يعني مش عمال يتشنج لا بقه بيلعب ايده بتنطر كده. These are subtle convulsions. الأبو قالوا really non-compaction, no criteria to fit 100%, decreased ejection fraction. And during the examination, after he finished the echo, while I was listening to him, he entered into an attack of tachycardia. This is his echo, and he was in an unsustained VTAC. This patient was given amiodarone. This is amiodarone. He had all types of arrhythmias present in him, and we find if you find any arrhythmias like the PVCs in that patient or premature atrial contraction, I don't take them easily. He enters into unsustained VTAC, and when we realized, when we have done the investigations, he had a fatty acid oxidation defect, and fatty acid oxidation defects are all of them, mostly that having cardiomyopathies and arrhythmias. So I have to look at this abnormality in these patients and never to ignore inborn errors of energy metabolism in early life in these types of patients with arrhythmias, because early in onset of these abnormalities of long-chain fatty acid, they present early, they come with hypertrophic cardiomyopathy. If they present later in the same family, طفل أكبر شوية يجي dilated cardiomyopathy and heart failure. أكبر من كده على ما يجيلكوا قدس ممكن البارent يبقى عنده arrhythmia or a conduction defect. So the presentation differs with age. At what age will the patient come to you? So suspect inborn errors of fatty acid oxidation in unexplained sudden death or near miss death in infants, and infants with conduction defects or ventricular tachycardia of unknown cause. And this is my take-home message. I mentioned things more than once, and thank you.